Good afternoon and welcome to another Institute of Health Studies satellite seminar. We're broadcasting from the University of Plymouth. In the studio today we're very pleased to welcome Bob Gann. Bob will be a very well-known figure to many of you. He's Director of NHS Direct Online, about which he's going to speak today. Bob set up the Help for Health service as a registered charity in 1991, providing health information on self-help groups and other things. During the 1990s he also wrote extensively on consumer health issues, with a regular column in the British Medical Journal. He served on a number of national committees and advisory groups, and he was one of the 25 UK healthcare leaders to sign the NHS plan. He's now part of the national management team for NHS Direct, with responsibility for developing NHS Direct as a multi-channel service, and I think he'll be explaining what that means in his presentation. In the studio to discuss NHS Direct Online we have Annie Jenkin. Annie is a senior lecturer in emergency care here at the Institute of Health Studies at the University of Plymouth. And you've got me. I'm Ray Jones and I'm Professor of Health Informatics with a particular interest in the provision of information to patients and the public. What we will do in this next hour is first Bob will give a presentation for about 20 to 25 minutes. At the end of his presentation he will join us again here for discussion. That will be your chance to contact the studio. You can contact with your comments, questions on two different ways. First of all, you can use the telephone, and secondly, you can use email. Details of these will appear on your screen in a minute, and I'll tell you again after Bob's presentation. But if you have a pen and paper handy, you should note them now. You can phone in using your mobile or any other phone available on 01752 233 646, or you can email tvstudio@plymouth.ac.uk. As well as viewers down here in the southwest of England, we hope to have viewers from around Britain. In particular, we're expecting participation from Nottingham and Glasgow. It would be good for us to have some idea of how many centres and people are tuned in. So maybe one person at your centre could contact the studio using one of these methods during Bob's presentation in the next 20-25 minutes. It will be useful to know how many of there are viewing and where you're viewing from. So now we go over to Bob Gann.
Good afternoon and thank you for inviting me to give this satellite seminar. In the session I'll be talking a little bit about some trends in 21st century healthcare and how we're meeting those challenges in the NHS Direct service. Earlier this year, the Chancellor of the Exchequer, Gordon Brown, allocated additional funding to the NHS, particularly around information technologies. And he commissioned a banker, Derek Wanless, to produce a study of how we might spend that money most effectively in a 21st century healthcare service. And Wanless identified some major drivers, some major changes in 21st century healthcare. He suggested that in the new century, patients will want more choice and higher quality services. We'll have an ageing population living increasingly with long-term chronic diseases. We'll have new information and communication technologies that will create new opportunities for reaching those people. And we can expect to see major changes in the way in which health professionals work. And NHS Direct is just one example of those new ways of working, and I'll come back to that. In particular, Derek Wanless looked at how we might make an investment in supporting people in taking responsibility for their own health. And he suggested that through media such as the internet, digital TV, people will receive information and increasingly use advice interactively. And being a banker, Derek Wanless put a cost benefit to that. He suggested that for every £100 we spend on encouraging self-care, will deliver £150 worth of benefits. And those benefits are in areas like increased abilities for people to care for themselves, reduced inappropriate consultations, improved compliance with medications, etc. One of Wanlis's key changes was the number of people living with chronic illness, a concept that is often linked to the idea of the expert patient. Nowadays, many patients and many clinicians would recognise that a patient can know just as much as a clinician about coping with a particular condition. Patients will need support and information to help them in that process in areas like recognising and acting on symptoms, dealing with acute attacks of the condition, making the most effective use of treatments, and accessing the range of social care and support available to them. We have in the NHS now an expert patient strategy, a new approach for chronic disease management in the 21st century. And there's a programme of work just about to start to deliver training and support opportunities to enable people to live as expert patients with chronic illness. The other major trend that Wanlis and indeed many others have identified is the information revolution. Over 500 million people in the world have used the internet. We have around half the population in the UK now with access to the net. Latest figures suggest about 43% of UK homes are connected to the net, and many people also have access in the workplace and in educational settings. 75% of all web users say they have accessed health information, and that's as often as almost once a week, 3 or 4 times a month. Many people say that health is the most accessed part of the internet apart from pornography. We have 100,000 health websites. An article in the British Medical Journal suggested that figure. And obviously those are websites of incredibly varying quality, some very good, some extremely poor. One of the challenges we have in the NHS, I think, is to help people to navigate that confusing maze of resources and get access to the best quality information. So the information revolution creates enormous opportunities. And I'll go on later in the presentation to talk about ways in which we've used a range of communication technologies to help people to get that access that they need. So NHS Direct. NHS Direct is a combination of methods in which people can access information and advice. This is the clinical assessment system that all NHS Direct sites use to shape the inquiry when you telephone and speak to a nurse. We have 22 NHS Direct call centres operating every hour of the day, every day of the year, providing people with the opportunity to speak to a nurse about any issue that's worrying them. Typically, NHS Direct tends to be used by parents of young children, for example, with a crying baby in the middle of the night, not sure whether they need advice from a healthcare professional. In the past, perhaps they'd have had the option either of caring for the problem for themselves, with all the worries that that entails, or calling out their doctor in the night, which for many people is quite a serious escalation of the problem. NHS Direct offers a middle way, offers an opportunity for supported, appropriate self-care. And this clinical assessment system is the way in which we have the knowledge available to nurses at their fingertips to do that. This is a typical NHS Direct centre. This is our centre in Wakefield. And as I said earlier on, we have 22 of these around the country, typically serving a population of about 2 million people. Staff in the centres, in addition to nurses, include initial call handlers who take the call and take the initial demographics before passing the caller on to an appropriate response. And we have information people who provide a wide range of everyday information, everything from details of support groups to where's the nearest late night chemist tonight because I want to go and buy some paracetamol or some Calpol for my crying baby. NHS Direct is becoming increasingly busy and increasingly popular. Last year we did 6 million calls from members of the public, and we're projecting that by 2004 we'll be dealing with 20 million calls. And the reasons for that rapid increase are twofold. Firstly, just increased public awareness of NHS Direct, and we know from the regular surveys that we do that national awareness is now around 60% of the population have heard of the NHS Direct number. And secondly, increasingly NHS Direct being used as the out-of-hours access point to primary care. And increasingly primary care providers are routing their out-of-hours calls through NHS Direct rather than making their own separate local arrangements. What we are beginning to be able to demonstrate in NHS Direct as we get increasing volumes of calls is some quite significant changes in people's behaviour when they contact NHS Direct. This slide illustrates the lavender coloured bar suggests what people felt they needed to do before they contacted NHS Direct. And the pink bar is the action they did take once they'd had the conversation with NHS Direct. And as you can see, the majority of people contacting the service think they need access to professional health care from their GP within the next 24 hours. And having spoken to NHS Direct, that number falls very significantly, and you can see increasing numbers of people who are satisfied either with a routine GP appointment or with self-care with advice from a nurse. And you can see a more than doubling of the number of people who are satisfied with self-care. What we're also demonstrating is a small increase in the number of 999 attendances, because we have occasionally spotted an urgent problem which perhaps the person was unaware of when they telephoned NHS Direct. NHS Direct was first launched in 1998, and it's been gradually implemented over the last 3 years, and there's now full coverage of England and Wales, and a similar service currently being implemented in Scotland called NHS 24. Having introduced the telephone service in 1998, we've now gone on to introduce some other ways of people contacting NHS Direct. First one of those was fairly soon after the telephone service was launched, this time in 1999, we launched NHS Direct Online, and this is the web service for the public as part of the NHS Direct family of services. And this is just a screenshot here of the NHS Direct homepage. You can see on that several things. It's very strongly branded with the NHS Direct identity, so you're reminded on every page of the telephone number, and you can call that number if you're not sure what to do. There's several different options of ways in which you come into the website. There's an encyclopedia of about 500 different health topics. There's a self-care guide that allows you to check symptoms and come up with an appropriate action for common everyday coughs, colds, rashes, etc. There's advice on healthy living, and there's a large database of NHS services where you can find anything from the nearest chemist to the shortest waiting time for treatment. And down the side of the screen there, some hot topics, and these change very regularly. These are current issues in the news that we update very regularly. The website now receives about 7 million hits a month from about 300,000 unique visitors, and it's one of the busiest public sector websites. I think it's about the 6th most popular public sector website in the UK. We very recently, in the last year, have introduced an online inquiry service where if people can't find what they're looking for on the website, they can submit an inquiry by email, that's researched offline for them, and within 2 days an answer is posted on a secure web server and they can go and pick up that answer. I'll come back to some of the potential for that type of technology for clinical advice towards the end of the presentation. We recognise that although around half the population do have access to the internet, many people don't still around half the population don't. And it may well be that the kinds of people that we most want to reach with good quality health information are exactly those people who don't have the internet in their home, or perhaps aren't in employment or aren't in education, so they don't have access in those environments either. So we've developed a series of touchscreen information points. This is a picture of one here, and those have now been installed in about 185 or so settings, almost 200 settings. Settings like shopping centres, railway stations, National Health Service premises, pharmacies, libraries, etc. And it provides a cut-down version of NHS Direct Online that works in a simpler touchscreen way. And that's proved very popular as an additional option in which people can get access to our information. Now, clearly, for many types of health information, particularly sensitive, confidential things, a public touchscreen environment is not the most appropriate. But for many other things, particularly healthy lifestyle information or service information, where to find the nearest service, it's very appropriate, and we're looking at ways of taking that approach forward in future. We are particularly excited about the possibilities around digital interactive television. Earlier this year and during the course of last year, we funded 4 NHS digital TV pilots, and the one on the screen behind me was a service that we piloted in Birmingham called Living Health. It was broadcast on the TeleWest platform and provided people subscribing to that service with 4 main service options. They could view video on demand on health topics. They could view content from NHS Direct Online, which we'd redesigned so it worked more effectively in the digital TV environment. They could see the NHS Direct nurse on their television screen when they were speaking to the call centre. And they could also book an appointment with their GP. And some of the GPs in Birmingham allocated part of their appointment diary to the NHS Direct digital TV service. Probably the last 2 of those things, the NHS Direct InVision service, where you could see the nurse, and the GP bookings, attracted by far the most interest in the media and in policy making, but actually had fairly low take-up from the public. Possibly we think it was almost too good to be true. It was something that people weren't particularly familiar with yet, but will become increasingly so in future. With NHS Direct InVision, the nurse couldn't see the caller, so it wasn't a full 2-way television supported conversation, but it did have the advantage of the nurse being able to illustrate on a video screen behind her options when making an initial diagnosis, and also to show visual images to support the advice she gave over the television. The GP appointments, again, as I say, people almost felt that was too good to be true, and there were examples of people booking the appointment online and then telephoning or going round to the practice to make sure that that was okay. And I think we need to get through that credibility gap, perhaps, in the use of those technologies. Those pilots were very successful. We've had a recent evaluation of them, which has just been completed. We found great success in reaching the population. More older people and more men than use other NHS Direct channels like the telephone service and like the online service. We are now funding a national rollout of NHS Digital TV from April next year and see particular opportunities for reaching a wider audience and delivering both information and increasingly a range of transactions, including bookings via the digital television service. We never forget that for many people, still, the most convenient channel, the most convenient medium is none of those electronic mediums at all. It's simple print. So we've produced a print version of the self-help guide, which is on the website, simple self-care, home remedies. We've distributed about 1 million copies of that self-help guide, particularly to parents of new babies. And that's proved extremely popular. And we're looking at ways of increasing the distribution of that in future. So what channels do we now have available for the public, for patients through NHS Direct? Just a summary of those. We have 22 call centres, all using a single decision support system. We have a website reaching 300,000 unique visitors a month. We've got almost 200 touchscreen kiosks. We've distributed 1 million self-help guides. We've piloted 4 digital TV services, and we're implementing a national service for next year. How much does that all cost? Well, around £100 million a year. A great deal of that cost, though, is in staff costs, particularly for our nurses who work every hour of the day, every day of the year in delivering the NHS Direct service. And we're very confident that NHS Direct is the most fully developed public multi-channel service in the world. So what are we going to do next? And just looking forward into 2003 and beyond, and I think these are really the main areas of future development. We need to develop much more information in the most accessible ways possible, particularly information in languages other than English, and information at different educational levels. And those levels will range from the level of the expert patient, which may be very similar to the kind of information a clinician needs, to information perhaps for people with learning difficulties. And that's a piece of work that we're starting from April next year. Secondly, we want to look much more at how we personalise information, so that it's not just come to NHS Direct Online and get the same information as everybody else, but get information that's particularly targeted at you. We're developing a project at the moment called Health Space, which will create for users their own personal zone on NHS Direct Online, which they can use to record their own health diary, the medications they're taking, bookmarks to relevant websites, but increasingly the possibility for that to provide a public portal to their full electronic patient record, thereby fulfilling the NHS plan commitment for people to have access to their own electronic health record through an appropriate medium. Thirdly, we are looking at the possibility of not only providing information online, but full clinical advice, and allowing people, as an alternative to coming in via the telephone, setting up a web chat with an NHS Direct Online nurse. We're doing a small pilot on that at the moment, and we're looking at issues like, is it clinically safe? Do nurses have the skills to work in that environment? Is the time it takes, because it takes considerably longer than a telephone call, worth it? And if that's successful, we'll look at rolling the service out in future. And then finally, there's a national policy commitment now, following on from the inquiry into the heart disease issues at Bristol Royal Infirmary, to develop a national knowledge service for patients and professionals that links up much more closely the information that we have available to patients with the information for clinicians, recognising that essentially it's the same national knowledge source, but we need to interpret and deliver that differently for different audiences. It's been suggested that shared decision making may be the most important change in medicine in the next decade. Clinicians and patients bring considerable expertise to the partnership, but it's only a real partnership if people have equal access to good quality information. In NHS Direct, we're making considerable strides in that direction, and there's a lot more still to do. So thank you very much, and back to Ray Jones.
Okay, thanks very much, Bob. And while Bob comes over to join us here, ready for the discussion, and just remind the viewers out there in wherever that you can telephone us now on 01752 233 646, or alternatively you can email on tvstudio@plymouth.ac.uk. I wonder, Bob, if I can start off the discussion. In discussions with a number of people over the years, I've found that a number of clinicians sort of remain sceptical really about the benefit of services such as NHS Direct, online and so on. You gave us a figure there for the cost, but how do you actually convince the sceptics that it has been worth it?
I think it's a process that's going to take some time to demonstrate, because it's only when we get very significant numbers of contacts with NHS Direct that the real benefits are realised. We have an ongoing evaluation by the University of Sheffield that's measuring both the volumes and activity in NHS Direct, but also the impact on other NHS services and whether it is leading to a decreased impact on those areas. Findings so far suggest that the volume of demand is not particularly affected, but the appropriateness of that demand probably is, and there is increasing evidence now of, as I showed briefly in the presentation, of improved self-care, but also the calls that the appointments that are taken up in the NHS are more appropriate.
Okay, we have a call in from Glasgow. So, hello Glasgow, nice to hear from you. We have the question, please.
Hello, can you hear me?
We can.
Yep.
My name is Dr. Harpreet Coley. Sorry, there's only one of me here, and
you need to mute your TV, Harpreet.
Yeah, I'll turn the TV off. I'm getting the echo from that. The question I had, you obviously mentioned NHS 24 in Scotland, which is providing the same service north of the border. I was wondering about other countries and if there's anything that NHS Direct can learn from them, and indeed what interest there is from other countries in what's going on in Britain.
Okay. So I guess two things. What can we learn from them and what can they learn from us? When we first developed NHS Direct, there were a few models in other countries that we were able to follow on from. Some of the American health maintenance organisations, particularly Kaiser Permanente in America, had call centres for their members that not only dealt with kind of membership inquiries, but also did provide nursing advice. But the scale of what we've developed in the UK and the national coverage is completely different from anything anywhere in the world. So what we're now finding is it's more a question of other countries picking up on our knowledge. Clearly the NHS 24 development in Scotland is based very significantly on NHS Direct. But I think what we have found is that the process of reviewing and refining the service to implement it in Scotland has had significant advantages in the in England, and we've learnt back from Scotland and put that into practice in England. Overseas, we are currently in discussion with the Australian Health Department about implementing a very similar NHS Direct model in Australia. Australia, a very obvious setting for NHS Direct, a technologically advanced society but big geographical spaces, and I think they view NHS Direct as almost like 21st century flying doctor equivalent, I suppose. So Australia particularly, but a number of other countries interested as well.
I know that Harpreet's actually hung up the phone to listen to the TV, so thank you very much, Harpreet, from that. We have got a question actually just come in from Plymouth, and then we'll go to Annie. There's a question here from Institute of Health Studies in Plymouth, Val Hyde, who says, given the rapid rise in the number of nurses working for NHS Direct and the current workforce crisis in core and new service nursing provision, is there a possibility that NHS Direct will undermine the services that exist for those whom self-care is no longer appropriate?
Yeah, very, very valid question. When we first set up NHS Direct, and obviously there was a lot of initial recruitment, there were certainly concerns from local healthcare providers that we would be poaching their nurses, and there were some early difficulties around that, and those are currently being experienced in Scotland. I've read a fair bit about that in the health press. I think our feeling around that is that NHS Direct is part of the NHS. We're not some alternative service, and we are now developing a number of ways in which we can work more closely with local healthcare providers, local health trusts, to look at things like shared posts, rotating staff. Many people move from NHS Direct back into more face-to-face care. Many people come into NHS Direct from face-to-face care, and I think that will just become an established pattern. Many of the nurses in the call centre where I'm based in Southampton also do work in settings like health visiting, accident emergency nursing, and I think we're working through that quite successfully now.
We'll get to you in a minute, Annie, but I've got another call coming in from Torbay, Veronica Maynard.
Hello, thanks very much for a very interesting presentation. It's Veronica Maynard from Torbay. I've just got one question. I was just interested to know what training are given to nurses or healthcare professionals who are working at the NHS Direct Online call centres, and also how you evaluate the advice that they actually give.
Right. Okay. I'm very happy to answer the question. I'll try and do so in a minute. Just to make clear that I direct the non-telephone aspects of NHS Direct, the things I illustrate particularly in the presentation. I'm pretty familiar, I suppose, with the work of the wider telephone service, but I may have less expertise than somebody in the direct call centre side of the business. I mean, all nurses coming to NHS Direct come with quite a high level of clinical competence to start with. I mean, they would be, a health visitor or ward sister, that kind of background. They have particular training in using the decision support software. That's probably one of the most important pieces of training, and indeed in communication skills as well. Every site has a nurse director who's responsible for ensuring the continuing professional development of those nurses. The evaluation of the advice given, every call is recorded through the decision support system and is also audio recorded as well. So there's every opportunity for clinical audit and for people to go back and review difficult inquiries with a peer support group. So there's a lot of peer support and a developing programme of clinical audit led by the nurse director within each site.
We've got one more person on the line, so we've got the lines are buzzing. So we can take the next call, please.
Hello. Hi, this is Dave Hartland from Exeter.
Hello.
I'm just asking about the shared decision making by NHS Direct. I work for the ambulance service, and as your presentation at the beginning showed, there was an increase in emergency calls that NHS Direct have sent patients to the hospital. And I've seen a few of those, but some of those you don't have the luxury as a NHS Direct nurse not seeing the patient, and we do. I just wonder if there's another appropriate way of this shared decision making, i.e. not calling 999 for an ambulance, if there's an alternative practitioner who could go and see the patient rather than dialing 999.
Mm-hmm. Okay. The link between NHS Direct and ambulance services is an extremely important one, and probably about half of the NHS Direct services in the UK are actually hosted by an ambulance trust. My own site in Southampton is managed by Hampshire Ambulance Service. So we are looking at a much better join-up between NHS Direct and ambulance services, things like an integrated call centre for NHS Direct and the 999 calls. We're also, although currently NHS Direct is only staffed clinically by nurses, we're just considering at the moment some options for having paramedics in NHS Direct call centres, providing that kind of immediate paramedic advice over the telephone. So there are developments around closer join up with ambulance services.
And if the caller wants to come back on that.
Yeah, I mean, yeah, thanks very much for that. I'm just wondering if rather than the paramedic actually on the screen, I mean, it's still better to see the patient, and it's providing what's best for the patient and using the appropriate resources, because once the paramedic or the healthcare professional you send then can resource that patient to the right centre where they need to go.
Mm. Yes, an interesting idea. I don't know whether it's something we've yet thought of, but no doubt a view we could take on board. Yeah.
Okay. Annie, let's sort of pass over to Annie now.
I think
Jenkins.
Dave was referring to the paramedic practitioners that
Right.
we're just beginning to roll out down here in the southwest.
Yeah.
But I was just wondering, with the presentation with data protection, you said you're hopefully looking at a personalised healthcare space.
Yeah.
And so how are you going to protect patient confidentiality, and how are we going to sort of prevent people gaining access to others' very personal information?
Yeah. The work we're doing on the personal health space, obviously one of the most important issues around that is authentication and security of that web space. And that so far we've been developing at two levels. There's probably just an initial password protecting access to the personal web zone, because people put into that web zone what they choose to include, and people often are prepared to have things like their vaccination schedules, their blood group, that kind of thing, which is not hugely confidential. And I think there's a trade-off between the convenience of having that in an easily accessible environment with the security. It becomes a more serious issue, I think, if the personal health space links through to someone's full electronic health record. And clearly we want to be very confident that the person seeking to access that record was the person that they say they are. There's some work going on with the Office of the E-Envoy about a concept called a government gateway, which is an authentication series of procedures for a lot of transactions, things like tax records and social security information, schools information, that kind of thing. So we're working quite closely with them at the moment. In future there could be a whole range of authentications, like fingerprint technology and that kind of thing. But I think initially it'll be probably a combination of passwords and security certificates.
Do you think then that I mean, there's more confidence now in using the internet as opposed to the intranet or the NHS net? Because I mean, when a few years back, when NHS net was born, the reason for it was because people didn't trust the internet. They didn't trust the security of information being passed around, and sort of combined with that question is the health space going to in some way sort of complement or in a way compete with all the work that's going on with the electronic patient record, the electronic health record? How do those two things sort of fit together?
Yeah, I think that perhaps the short answer is that the health space will provide a gateway into the electronic health record. It's not exactly an electronic health record in itself. it's a way in which people might use a familiar technology, increasingly familiar technology, the internet, to keep not only their own personal information, but to link through an authentication gateway into the health record. So the work on developing the electronic health record is going on behind the scenes already, obviously, and there may be the option to link through health space if we prove that the technology is acceptable and that the authentication is robust enough. So I see it very much as a complement to the work that's going on around the electronic health record, and perhaps one of the ways in which people can get convenient access to it in future.
Do you think, though, that the professional views about the internet versus the NHS net now, that more people have more faith in the internet, because that was, and will the NHS, not fair to ask you this question really, but will NHS net continue, or can we actually get rid of it?
I think there will still be things where the NHS, as with any major organisation, will want its own intranet. It will want its own environment in which to do things. The significant thing, though, with access to electronic health record via the internet is the commitment in the NHS plan and government policy for public access to it. And there have been a number of expensive solutions like smart cards, etc., that have been suggested, and we at least need to test whether we can't use increasingly ubiquitous, readily accessible technologies such as the internet to deliver that.
Okay, we have a question from Exeter, please. Caller, please.
Hello, it's Richard Bramwell calling from Exeter. Speaking from an ambulance service point of view, just wondering if there's any evidence that the existence of NHS Direct is leading to delays in dialing 999.
Interesting question. Short answer is I don't think I know, and I don't even know whether we've got that information. What we would say, I think, is that the initial screening questions that somebody is asked when they call NHS Direct ought to mean that if a 999 response was the appropriate one, that it was a pretty quick route into 999 anyway. And I suspect that people are more ready to dial NHS Direct than they would be to originate a 999 call. So as long as those calls are appropriately triaged and 999 is activated when appropriate, I would hope there'd be very little delay.
Annie, do you want to?
Yes, I was just coming out from the 999 side of things at the moment, but I was just wondering what measures are being taken to identify benefits in terms of health outcomes in relation to NHS Online.
We've just had a Commission for Health Improvement review of NHS Direct Online. It's been very interesting to see the processes of CHI around clinical governance, which are obviously designed for proper healthcare settings, applied to an online service. And on the whole, that's worked very successfully. And we, although the report's not out until next year, got some very good results in the CHI review. One of the things that CHI have said to us, though, is that we need to be developing outcome measures in addition to just activity measures around NHS Direct Online. I think that's actually quite a difficult thing to do. Many people have tried in the past to develop measures of outcome or health gain around information provision. We have, as I showed on the slide, been able to demonstrate some changes in actions that people have taken. How far down the line we can go in terms of measuring a health benefit or a piece of changed behaviour, let alone an improved health status, is perhaps rather difficult to do. But we're being very much encouraged by CHI to develop that next year and onwards from there.
We still have the caller on the line from Exeter, I think. Did you want to come back with another? Oh, he's just gone. Okay, right, he has just gone. Can I Carrie sort of comment on that? It seems to me that the one area, as you move more and more into the personalised bit, it becomes easier actually to look at health outcomes, because with the general health information it's very difficult, whereas for example, if we were looking at the health space, I mean, you could imagine, you could do some randomised trials, you could have sort of measures of well-being and so on, I guess.
I think that's absolutely true, because firstly we've got a population that we can capture if we want to, but also we've got a more longitudinal relationship. Most contacts with NHS Direct are completely short-term, episodic. They just come and go, and we know no more about them. Through a personal health space which might build up with a whole series of advice that's been given from NHS Direct and been posted into that health space, we can track someone's experience in using NHS Direct and perhaps see some benefits from that.
Mm-hmm. Can I turn to the equity issue? I mean, one of the things about, as you know, I've got an interest in the kiosks and had an interest in these kiosks, but to come down here to the southwest, a rural area, kiosks probably work well in deprived urban areas where you've got a good number of people who could make use of them. Have you got any thoughts, any future ideas about what NHS Direct Online might be doing to get to sort of rural populations, apart from the internet?
We'd certainly want to provide an increasing level of kiosk access, and I think we're perhaps changing our thinking a bit around the way in which we do that. In the past, as you know very well, Ray, and have been involved in evaluating the kiosks, we have had our own NHS Direct branded kiosks, and they do nothing else other than that. There are a whole range of kiosks now. I mean, we've all seen them in railway stations, and every time I'm in a motorway services there's a kiosk there with links to various resources. And it may be a better approach, I think, to provide NHS Direct content on other people's kiosks rather than just our own boxes. We're also looking at some of the other places in which people naturally go for information. Obviously places like public libraries, and we've done a bit of work in public libraries promoting access to NHS Direct Online through that. And we've got a current piece of work that we're just starting with UK online centres, and there are a lot of those. I mean, I was in rural Dorset 2 or 3 weeks ago and went into Wareham railway station, and actually on the Wareham railway station platform area there was a UK online centre where people could go and just use a series of public access terminals with access to the web, and those kinds of environments might perhaps be helpful in future. There's also been work done looking at the role of the post office as a kind of information general practitioner. Pilot work in Leicester on that recently, and that's another possible access point increasingly, I think.
Yeah, I just want to pick up again another point with cultural aspects of NHS Online and Direct, obviously. Within the southwest, we're clearly seeing increasing numbers with refugees, with people from different cultures and ethnic backgrounds, and I haven't seen anything on the literature that's indicating you're going to broaden your language base, really.
Okay.
What's happening there?
Yeah, we recognise that as a major need. We within the telephone call centres, although we do have staff who have a range of language skills, or perhaps from minority ethnic populations themselves, we don't route calls specifically to people with language skills, because everybody in NHS Direct is a generalist who can answer any inquiry using the support software. So the way in which it works in the call centres is that we subscribe to Language Line, which is a telephone interpreting service used in a lot of public sector organisations, the NHS, the police, social services, etc. We are next year implementing a national translation and interpreting service through NHS Direct. And on the website we have a series of audio clips in languages other than English. And the reason for doing it in audio was that we were finding from the advice we had from multicultural health advisors that quite often people weren't necessarily literate in their own language, let alone in English. So audio is quite a good way of doing that. I think the most optimistic area for developing this further is the digital TV work. and the opportunities for developing content in languages other than English, the fact that take-up of digital TV amongst minority groups is quite high. If you've got 200 channels, you've probably got the option of having a number of them in languages other than English, and I think that's probably our most preferred mechanism in future for taking that forward.
And I expect there's also scope with, if you think this is technology for the future, there's also scope with perhaps working with children and schools in projects that would develop and make some of the information sort of appeal to adolescents as well as the child. That might be.
Yes, I think at the moment NHS Direct Online is, pretty much all things to all people and isn't particularly targeted at special populations, but certainly young people, likely to be quite good web users, likely to want information presented in some rather more lively and interesting ways. I think if you're going to do it, you've got to do it properly, though. I mean,
absolutely.
You don't want to end up looking like some trendy vicar, do you? I mean, my kids would probably be extremely discriminating about what they thought was appropriate in use in that environment. We think the web chat with a nurse may actually be quite popular with young people too, and young people who may not like using the telephone but spend a lot of their time on chat rooms may find that web chat environment particularly helpful.
Is there any idea of trying to bring in mobile technology into this? I mean, how do the mobiles go? That's what the kids all use, isn't it?
That's right, yes.
Excellent.
Yeah. We have started to look at mobiles in quite a small way so far, but looking at possibly three main things. Simple information on mobiles. The self-help guide works quite well on a mobile because it's a series of short questions with an answer in response to those, and at the end of a series of questions and answers, a suggestion for action, which is often make a telephone call. And that suggestion with a phone in your hand is quite a powerful message. Secondly, find your nearest local service. I was looking a few weeks ago for a late night chemist, and I'd forgotten which one it was in Salisbury where I live, and I ended up having to telephone NHS Direct to find that information out, and because it was a non-urgent call, NHS Direct had to phone me back, and I was waiting for about 20 minutes to find out where this chemist was. Had I had that on my mobile, that would have been incredibly useful, and we've developed some mock-ups of that. Now I think the third area is using text, SMS, and by far the most popular technology with young people, and we've done some development work around using SMS for reminders, particularly for turning up for appointments, taking medicines and attending blood donor sessions. So each of those we've done some demonstration work on. We haven't launched it as a live service yet, but it works.
Annie, have you got any other?
It's just gone out of my mind, but it'll come back again. And
it's just going back to the kiosks and the rural one. I mean, it's just struck me that you could perhaps have mobile kiosks, because I mean you do have mobile libraries. I wonder if you have kiosks with mobile connections to the internet. I mean, in the same way that the laptop here has got a mobile connection to the internet. So that could be one way of taking that forward.
Could be good.
Yeah. I don't think we have any other questions at the moment from anybody else. I think if we're running out of questions, I think we'll call it to a halt. So thank you very much indeed for everyone's participation today. Thank you particularly for Glasgow for your phone call, and Exeter, Torbay, Plymouth for all your questions. Thank you very much to Bob Gann for coming down here, Annie Jenkins, and we look forward now to the next IHS seminar, which is in January. On January the 16th we have two seminars. At 12 o'clock we have Professor Mike Hyland, who will be describing new ways of thinking about complementary medicine, and at 2 o'clock the same day we'll have Dr. Peter Drury, who's head of the Information Strategy Unit for the Department of Health. He'll be discussing the NHS Information Strategy. As always, these seminars are open to all, so do put the dates in your diary, tell your colleagues and friends, and we look forward to your participation. Have a nice Christmas. Goodbye.